Hey, good afternoon, guys. I'm Chris Welker. This is Samir. We're both the leadership for the Aerospace Medical Association here at McGovern now. So we have a very prestigious history as of last year. So it started last year. We actually have a co-founder right here in front. This is Josh. But we're really glad you're here. This is the first of hopefully 3 lecture series for this semester, and then we'll do a few more in the spring semester, as well as possibly a NASA tour as well. So we're trying to put that together for everybody. It was a very successful time last year, and I think a lot of people got a lot out of it. But fortunately today, we're going to start off with Dr. Bungo. I won't get into his introduction since I think he's I won't spoil all of his history and stuff, but we're very fortunate to have him here, not only, speaking today, but also just on faculty here at McGovern. He has a ton of experience in this space, or no pun intended, I guess, but it's, we're just really glad to have him. He's been a great mentor to all of us, future hopefuls in the aerospace medical community, and so we're just really glad to have him. Thanks, sir.
Thanks, I appreciate that. Pull up some slides here real quickly. Today I wanted to talk to you about aerospace medicine and more particularly about space medicine. And that's a relatively new field, as you can imagine, but if you think back over the history of humankind, we've been fascinated with flight for millennia now. In fact, Icarus, the son of the inventor Daedalus, was probably the first aeromedical casualty. So some disclosures before we get started. I have no financial disclosures relative to this presentation to make, other than I still do research for NASA and receive funding for them. A lot of the figures you see in this presentation are from Mike Barrett's classic textbook. And Mike Barrett's wife, actually, Michelle, is a faculty member here at UT in the Department of Pediatrics, so we'll give a little shout out there as well. And then other images here are from the public domain. So what is this thing, space, okay, that we're gonna be talking about? Well, this graphic here shows you a little bit about what's going on here. At about 15,000 feet, if you all remember from your basic hematology lectures in the oxygen dissociation curve, at about 15,000 feet, the pressure is such that your PO2 is only about 45 millimeters of mercury. You start getting on that steep portion of the curve. And yes, there are people clearly around the world who live at greater than 15,000 feet, but they are chronically hypoxic. By the time you get to 34,000 feet, even at 100% oxygen, you need pressure in order to breathe. Going up further, okay, to 50,000 feet, there's no respiratory gas exchange possible without a pressure suit, because at that point, just the partial pressure of the CO2 in your system and the water vapor pressure consumes the entire differential between that and the ambient pressure, and you can't have gas exchange over those alveoli. By the time you hit 63,000 feet, you've reached a point where body fluids vaporize. And then, if you're fortunate to go to 50 miles, the US Air Force will afford you astronaut status. That has become a big thing now with the advent of space tourism and who actually gets up into space and who doesn't. As you go further and further, you see that up at about 124 miles, no aerodynamic support is sustainable. By the time you get to 440 miles, the molecules are so far apart that they're not even considered anymore to be in a gaseous state because there's no molecular interactions, although they still are affected by gravity. So if you think of the Earth, okay, being less than 8,000 miles in diameter, okay, and it's only about 12 miles between here and the time you vaporize your body fluids, okay, you realize how thin this atmosphere is. In fact, if you were a bird and wanted to fly from here just down to the Johnson Space Center here in Houston, you'd only get as far as the intersection of 45 and Beltway 8 before you reached that limit. If you were actually to take surface roads instead of flying like a bird, you might make it to Hobby Airport. So think how geographically close we are to space, yet how physiologically far we are from that environment. Now, as was mentioned, I've been doing this thing for a long time. It's been several decades. I arrived at NASA at the beginning of the Space Shuttle program. Fortunately, that was in the early 1980s, and pictured here is mission control at the time that the first Space Shuttle was landing. And there is an old cardiologist, a young cardiologist there with a lot less gray hair that he now supports. But we were fortunate to start there. By 1985, we were doing the first echocardiograms aboard a United States spacecraft. And by the time 2009 rolled around, we had the first exercise echocardiograms in space. And you can see pictures of those two things here. So this environment of space, as we just pointed out, is lethal. Okay, you can't exist. There's no food, there's no water, there are extremes of temperatures, there is no atmosphere to breathe. But yet we have sent hundreds of people up into space at this point in time. And we've done that by putting them in an enclosed system where we've given them air, we've given them water, we've given them food, we've given them the shelter, okay, from the intense radiation, from the intense temperature swings, okay, from the lack of oxygen to breathe. Now, occasionally we do send them out on EVAs where we put them in more jeopardy with a lower pressure environment and less protection, although still adequate protection from some of the radiation. But we have basically given most of the creature comforts that we are used to here on Earth to our astronauts. Now, it is still a closed system, and there are issues with that, one of them being high carbon dioxide, about 10 times more than you're breathing here on Earth. But we've largely given them everything they need. That is, everything except gravity. We have not given them gravity. Gravity, which every living organism on the surface of the Earth has been exposed to for millennia. So we have had our whole development and evolution under the force of gravity. In fact, there's nowhere on Earth to escape gravity. You could be floating in the Dead Sea or floating in the Great Salt Lake. You're neutrally buoyant, but you're not weightless. You do not escape gravity. The only place you get a chance to briefly escape gravity is flying in an aircraft along a parabolic flight. The flight line, which is diagrammed over here. This is the famous NASA KC-135, affectionately or not so affectionately named the Vomit Comet. And as you can see, in order to obtain weightlessness, they fly a pretty harsh profile. And even at that, there's only less than 30 seconds worth of weightlessness. Now it is at least an environment we can use to test some things out. Up here is the now deceased Nobel laureate in physics, Stephen Hawking, who you might know was afflicted with ALS early in life and spent most of his adulthood confined to a wheelchair, except for those few precious 30 seconds here when he was weightless. But we do use this to test out some procedures. Here, Ray Seddon, an astronaut, is testing out how one might do CPR in space. But even with the brevity of it, there are still problems with the simulation, because here actually is how they ended up doing CPR in space. And you can see by the configuration of the individual, it's nothing like what was imagined before we got up there. So we are constantly looking for analogs. And so how do we know what we know about the human body in spaceflight? What's been our experience? Well, our experience, as you can see, has been largely in short duration space missions. This is a composite graph of US, Russian, and now more recently Chinese experience in space. And the vast majority of spacefarers have been up there for less than 3 weeks. Most of these actually happened during the space shuttle era of the United States, because we were able to fly multiple times per year. We were flying crews up to 7. But then as time went on and the Russians developed the Mir space station and then the International Space Station, came along, we have had more experience in the long duration flights. But even then, okay, there was a substantial number now that the space station has been active for about 30 years. There's a substantial number in the 6-month range, a little less so in the 1-year range. And anything greater than 1 year in space is still anecdotal at this point in time. But what we do know is that a lot of body systems are affected by spaceflight. This is not meant to be an all-inclusive look at that, but as you can see, there are a number of systems that are involved. We're going to go through in a moderate amount of detail some of those, and then I'm going to briefly touch on the rest of these before we finish. But clearly, it doesn't allow the time for us to be all-inclusive or even delve into one subject. Any one of these systems could be a course, let alone a one-lecture series. So what I hope it does is give you a little overview, but also pique your interest into what happens during space flight. Let's start with radiation. That was one of them. And we already mentioned radiation being a very significant environment. Just how significant is that environment? Well, fortunately for us here on Earth, okay, we are protected to a large degree from radiation. In fact, we get about 3 millisieverts of radiation per year existing at spaceflight. You take a lot of red-eye specials from LA to New York and you got goes up from there. Okay, but generally we're about in that area. We're protected by what's known as the Van Allen belts that concentrate radiation, divert it. It does concentrate it in what's known as the South Atlantic anomaly, which is a particular area that any orbiting spacecraft passes through, and so they get a little extra dose of radiation as they do that. But for those of us here on Earth who aren't, sitting out there in a buoy in the South Atlantic, we are subject to only about 3 millisieverts of radiation. Well, what is 3 millisieverts of radiation? Well, 3 millisieverts of radiation, okay, is about a third of what you'll get with an abdominal CT scan or so. So you'll get about 8 to 10 millisieverts of radiation. For all those patients you've seen in the emergency room who come in with belly pain and they all get, CT scans instead of a physical exam, that gives you an idea how much radiation we're giving them. Or they get a pulmonary angiogram for their shortness of breath, the same thing, about 10 millisieverts of radiation. And the National Academy of Science has actually decided that all radiation is bad. Okay, there's no such thing as good radiation. Yeah, I know we give radiation therapy to cancer patients because we're killing cancer cells. So I guess if you're a cancer cell, radiation is still bad. So radiation is basically bad. There's no good radiation, and as the level of radiation goes up, the risk of radiogenic carcinoma also goes up. So that for every millisievert of radiation, your risk of dying, not getting, but risk of dying of a radiologic-induced carcinoma goes up by about 0.005%. So again, a CT scan is not an innocuous test, but of course, the risk-benefit ratio is why we continue to do that. As another example, if you're a radiation worker, the Department of Energy has put your annual limit somewhere in the 20 to 50 millisievert range. Okay, it differs by your occupation, so it could be listed, if you looked it up yourself, it might be listed as either 20 or 50. What does that mean for 6 months on the space station? Well, 6 months on the space station is roughly about 80 millisieverts of exposure now, and that's for the crew members who are not going EVA. All right, so everybody's getting their 80 millisieverts. Some of them are getting 120 millisieverts or more. Okay, but everybody's getting the 80 millisieverts. 8 CT scans in a matter of 6 months. Right? If we want to go to Mars, it's about 125 millisieverts in the 180-day transit to Mars. Couple that with the fact that you're spending about 1.5 years on the Martian surface because you need to wait for the next window of opportunity to come back, you're collecting another 125 millisieverts. And then you're returning to Earth for another 125 millisieverts. So a trip to Mars is going to be hot stuff. And I say that with tongue in cheek. And we know from data in the laboratories that when you irradiate chromosomes, you do get translocations. And we've mapped this out of number of translocations against radiation dose. And interestingly enough, when we look at astronaut data, we find that the astronaut data here in the triangles falls pretty much along the lines that we have in our experimental methods. So this is not just conjecture, this is documented science. Well, we don't have time to spend too much on every system, so let's also talk a little bit more physiology about what happens in space. You enter the spaceflight environment, you're up there on the rocket, and then all of a sudden, you know, somewhere maybe, depending on your vehicle, somewhere around 10 minutes, the engine's cut off and boom, abrupt translation into a weightless state, okay? Now, in truth, it's microgravity. There's about 10 to the minus 6 G, but at that level, you'll hear it termed 0 G or weightlessness. What happens immediately is the hydrostatic gradient is abolished. All of us standing here on Earth, okay, blood is pooling in your lower extremities. If I need to prove that to you, if you happen to have old veins in your hand, you can see the veins in my hand are collapsed. As they move down here, okay, they'll fill up. Even though I have venous valves, okay, I don't have as many valves in my upper extremity as I have in my legs. So your legs prevent a lot of the venous valves in your legs prevent you from walking around like an elephant, but nevertheless, there is a hydrostatic gradient there. And depending on how tall you are, okay, if the pressure in your heart is at your right atrial level is 0 or 5 millimeters of mercury, again, depending on how tall you are, the pressure in your venous system at your legs may be about 90 millimeters of mercury. So there's a considerable hydrostatic gradient. Well, gravity's gone and you're in space immediately. That gradient's gone. So there's an immediate central encephalad shift of fluids that occurs. Your neurosensory system all of a sudden doesn't have gravity anymore. So your semicircular canals are happy because they're sensing rotational vectors, but your otoliths are linear accelerators. They're sensing linear acceleration by moving forward or the gravitational force that's pulling down on me. All of a sudden, they don't know what to do. They've got thousands of years of history of saying, that's down, okay? And there is no down anymore. And so you're subject to what we call space motion sickness, sudden projectile vomiting. Your musculoskeletal system is unloaded. You don't need to stand up anymore. There's no force pulling you down, okay? If you were just to relax, okay, and do nothing and just float there, you'd assume what we call the spaceflight position, or somewhat like a fetal position, because of the relative difference in the strengths of your muscles here on Earth, okay, that pull in certain directions to help keep me upright, okay, or keep me against the force of gravity. They're no longer opposed by gravity. So they'll find their neutral positions. Your spine lengthens, and as back pain has become a significant problem because it lengthens, the disc spaces are decompressed. There's an increased cardiac output to deal with that cephalid shift, okay, and the decreased vascular resistance. You get facial edema and nasal congestion, again, because fluid shifts are now where you had maybe a negative pressure in the head. Even if you had a 0 pressure in the head, that's a relative positive pressure to what you had here on Earth. We talked about the space motion sickness and spatial disorientation. And then given some more time, the muscles not having to work against gravity atrophy. As the muscles atrophy, so does the bone, because we don't have to stand up now. So particularly in the long bones of the spine or the leg. After days or weeks, you readjust your level, your blood level, to match the new normal. Your red blood cell mass decreases to match the decrease in plasma volume, so that you're relatively stable hemoglobin hematocrit. Your symptoms of space motion sickness resolve as you become accustomed to the changes in neural input. And as even more time goes on, there are more adaptation things so that the loss is stabilized. You reach new plateaus. One thing that does happen, and we're going to talk about this in more detail a little bit later, is that because of the continued increased volume in the calvarium, there are neuro-optical changes that occur. And they're here in red because we really don't have a good idea of exactly what's going on just yet. So, technical failure. Okay. So let's talk about the cardiovascular system a little bit more, since I really kind of started on that a little bit. And besides, I think it says cardiology on my lapel, so we'll talk a little bit. As I said, one of the things that happens is this fluid shift. And as you notice, when you go into the microgravity, it goes into the central encephalad region. You adapt, but now you got to come home sometime. Once you come home, gravity is reintroduced on an organism that has 15% less plasma volume. And so the ability to stand becomes impaired, and orthostatic intolerance, and in the worst case scenario, frank syncope, is a potential consequence. As I showed you in one of those other slides, we were able to do some more cardiovascular examinations as we were able to introduce more instrumentation into the shuttle and then International Space Station environment. And one of the concerns was because of this decreased cardiac load over time, the heart's a muscle. We know these skeletal muscles atrophied. The big question was, did the cardiac muscle also atrophy? So in order to try to prevent that, the crew members on there exercise literally 2 hours a day, every day. Think about that, okay? I mean, they love it because it's their one kind of tie to gravity that they no longer have. And we'll show you some of those countermeasures again a little bit later in the talk. So we want to know, was this exercise doing enough? And what we did see was that left ventricular mass was preserved after 6 months on the space station with the 2 hours of exercise per day. So that's the good news. The bad news is what happens if the crew member's sick or injured and can't exercise? Okay, now we didn't test that hypothesis because that would require not treating. It's sort of like doing a study here on Earth. You know, we know that antibiotics cure pneumonia. Let's see what happens if we don't give somebody antibiotics, right? So we didn't do that experiment, but that concern is still out there. The other thing that we learned was that it was actually related to what you did before spaceflight. So down here in this graph, in the lower right-hand corner, for those who are remote and can't see my pointer light here, we plotted the relative change in the cardiac work that was being done in flight versus what they did pre-flight. So if you were a couch potato, and none of the astronauts were truly couch potatoes, but if you allow me that little bit of hyperbole, if you were a couch potato, and then all of a sudden you started working out 2 hours a day, okay, you built muscle mass, okay, and you did build cardiac mass. And if you were a very conscientious athlete before flight, and then went into space, even 2 hours a day was not enough to maintain your cardiac muscle mass. So on average, yes, the data did show that there was little change, but it was directly related to the delta between what you did on Earth and what you were doing in space. Bone is another significant problem. Now, we talked about bone loss in space. But bone loss happens in bed rest, and we often use bed rest as another analog for space flight. I showed you the KC-135 flights. We use bed rest, and so you can relate this to, again, the patients that you see. Bed rest is also an analog for space flight, an imperfect one, okay? But nevertheless, we can get some parallels. So shown up here are what happens to your bone density as you are in bed rest, okay, in the open squares, or you are a cosmonaut or an astronaut in space. And as you can see, the spaceflight experience is actually worse than bed rest, but you can see some parallels. So we decided to investigate this a little bit further in space. And here's a picture of Dr. Serena Anand calibrating the bone densitometer on the space station. And once again, I show her picture because she was a medical student here years ago. So A little shout out there to Mike Barrett, and now a little shout out to Serena here. So if we looked at that, we saw that bone loss did occur in all these areas, the wrist, hip, trochanter, femur, neck, lumbar spine, okay? The data in blue is from the Mir space station, so this is early in our long-duration spaceflight experience. It was the Soviet space station, not even the Russian one, but the Soviet one, so it was pre-1989. In green, the International Space Station, before they instituted some of the exercises devices we have now, and then subsequently in pink, before they instituted the devices, in green after they instituted the devices, and then in yellow with the addition of biphosphonate therapy, which we use typically for osteoporosis here on Earth. But once again, this is just bone density. So we know we can do some things to prevent the loss of bone density, but is the inherent lamellar structure of the bone the same when it's reconstructed in space as opposed to when it's remodeled here on Earth? And we don't have the answers yet to that because we have yet to do bone biopsies on these people, although we have done muscle biopsies. I alluded to this before. The fluid shifts causing a headward distension. We've noticed that there have been ophthalmologic changes. Clinically, what they have been is a shift in your visual acuity towards the hyperoptic spectrum. In other words, you become more farsighted. But on ophthalmologic exam, cotton wool spots, choroidal folds being substantiated by optical coherence tomography. On MRI, flattening of the posterior globe with some papilledema in some subjects here, and distension of the optic nerve sheath. And when you looked at the MRI, the head in general, not just the globe, we saw that there was crowding of the brain in certain regions and displacement of structures around the fourth ventricle. And this, of course, doesn't go away because it doesn't go away in flight because at this point in time, we have no countermeasures. We don't fully understand the mechanism. We think it's all volume and not pressure or other issues, but we don't fully understand the mechanisms, and we have no countermeasures at this point in time. Now, still important, but a little bit away from the physiology into the psychology of spaceflight here. You know, when the space program started in this country with the original 7 Mercury astronauts, you know, they were deemed to have the right stuff, okay? They were test pilots. They were young male test pilots who were basically up for anything. You know, pull my fingernails out, I won't flinch. And they were deemed to be, you know, the ideal specimens. But they were up there for a short period of time. And they were, as you can see in this photo, on a pretty homogeneous group. As we put more and more people in space and added to the diversity of the population, not just from a genetic standpoint, but also from a diversity in their past social experiences or their countries of origin. And we kept them up there for longer periods of time instead of the brief 3 days or what have you during the Mercury program. You know, we found that there were issues in that. You are living in a can for 6 months on the space station, okay? It's a big can, okay? Maybe it's the size of a football field, and, you know, but it's living in your, you know, we all can relate to COVID now, right? It's like living in your house, okay, for 6 months. And you can't even walk in your backyard, okay? You can't go to the grocery store, even if you do wear that mask, okay? You are confined to your house. So we found that it's important to not just pay attention to the physical health of the crew, but to pay attention to their psychological health. And there are things that have been built into the program now. They have downtime built into their schedule so that they can either do their own thing. Some of them have brought, if they're musicians, brought their own musical instruments or other hobbies with them. They have time to connect with loved ones. by video conferencing. Social activities have become important. They typically revolve around meal times, but with the nice thing that's happened with a multi-ethnic crew, there are always holidays to be celebrating because, you know, throughout the years, somebody's having, you know, a holiday in some country or whatever in the world. So that's nice. But there's psychological and medical support available. Of course, training and preparation goes without saying. And technology has helped a lot. You know, we can give them movies or iPads or what have you to keep themselves, playlists to keep themselves occupied. But keeping the environment clean and pristine is very important to add to this psychological health. And you see some of those things here. And exercise has become a mainstay of not just physical health, but psychological health. But accidents happen, okay? So even without the physical changes, trauma is still a significant issue. I mean, when you look at now, you know, what's the leading cause of death, you know, among young people? It's usually some form of trauma, right? And this is just a quick little overview of what type of injuries we have seen in space, you know, what the injury type has been, what the location has been, okay, and what mission activity has caused that trauma. As you can see, mostly it's confined to the upper extremities because that's where they're being the most active. But I put in the mission activity because the job here is not just to treat the trauma, to treat the laceration or the sprain or anything, but to figure out why it's happened. And is it something to do with how much demands we're putting on them, okay? Is it something to do with, do they have enough supervision in doing these activities? You know, is it something about the communications? You know, is it because of the physiology or the psychology of spaceflight? You know, or is it a system issue that's playing into this? So it's a whole analysis, not just into putting a Band-Aid, in a sense, on the bruise, but figuring out the cause as well. So let's go back to this. Because I went over a few systems in moderate detail. Let me just cover some of the other things so you get a good overview before we move on to some other aspects of aerospace medicine. So we talked about the I'm going to just go around the clock here. We talked about the neuro-ocular syndrome. There is a loud, toxic environment in space. It's about a 70 dB environment, so it's very noisy. They turn some stuff down at night so that you can sleep, but it is a noisy environment. I already told you it has a high CO2. Of course, there's all sorts of other stuff floating around in there too, because it's not like you can open up the window and get a breeze coming in and clearing out the place. And then we do send these people EVA every so often. So they now have to get into a suit. They have to drop the pressure in that suit, okay? Because you can't, the space, although the early spacecraft like Apollo and Gemini were at reduced pressure and at one time 100% oxygen, we had the disastrous Apollo 1 fire, okay? And they said, well, we're never gonna do 100% oxygen again. So when you did that, you had to raise the pressure. If you were gonna have oxygen and nitrogen, you had to raise the cabin pressure in order to still have enough partial pressure of oxygen in there for the organism to function. And of course, as we did that, we finally got to the space shuttle environment and now the space station environment, and the decision was made to go to basically a sea level atmosphere. So it's 20% oxygen roughly, okay, with 21% oxygen like it is here on Earth. But when you go out into your spacesuit, you can't go out into a spacesuit that's pressurized at the same 14.5 psi that sea level is here, because the pressure would be so hard you couldn't move the gloves in that suit, because the pressure differential of zero pressure out there in space and 15 psi in your suit, you couldn't be able to use your hands against that. So the pressure in the suit had to be lower, okay? So one of the ways to do that is just increase the oxygen concentration and, you know, lower it all the way down. But of course, if you do that, now you're going from a high pressure environment to a low pressure environment. This is what any of you who are familiar with diving have experienced. You're in a high pressure environment when you're down there, okay? And as you come up from it, into the lower pressure environment, the sea level environment, you're subject to the bends or nitrogen bubbles in the bloodstream, which if they're in the joints, they call it the bends, but can also be neurologic hits as well. So we have the same issue there. We're going into the low pressure suits, pre-breathing, the possibility of exposure to bends becomes an issue. Pulmonary gas exchange we already talked about and goes with the dysphorism. We talked a little bit about the cardiovascular system, the spinal issues. The spinal issues have been so bad that we've actually had one crew member who had a ruptured cervical disc in space, okay? Doing some exercise, and because those little vertebrae weren't in the place they were used to be doing, caused some damage. Genitourinary issues, urinary retention has been a problem. In fact, a number of crew members have actually had to be catheterized in order to void during spacecraft. Again, the bone mineralization we touched on already, muscle atrophy, again, because of the same thing. And some investigators actually think that the tendons are altered biochemically with this muscle atrophy because of the loss of plasma volume. There's a subsequent loss of red blood cell mass. And we have also had an incidence of an internal jugular thrombosis on the vehicle. Maybe because of the stasis that's associated with space flight. Maybe because of, and I'll show you some pictures later, where the harnesses for the treadmill and everything fall. Trauma we talked about, psychosocial we talked about. Skin rashes are a particular problem. Almost everybody gets some kind of skin rash in space. And this may be, again, because of the environment. You know, we don't have the kind of sloughing of the skin and the hygiene and everything else that we have here on Earth, but may also be related to this other component, that there's decreased T cell function in space. We had the opportunity a number of years ago to fly an astronaut named Scott Kelly, whose brother, Mark Kelly, is an identical twin. He's currently the senator from Arizona, Mark is. And they participated in what was known as the twin study. So we had, better than an age-matched control, we had the identical twin on the ground from someone up in space. And so obviously their genes didn't change. I shouldn't say obviously, but yes, their genes did not change, but their gene expression did change during that, and the gut microbiome changed as well. We talked about radiation. You're dumping calcium into your system because of your bone demineralization. Renal stone formation is of concern. You know, a toothache is a problem too, because you have now this pocket. Okay, you don't have gravity, so you don't have drainage. So an abscess is a horror show in space. So dental problems are of concern. And again, you're orbiting the Earth every 90 minutes. A day is 90 minutes long. Day and night is 90 minutes long. So circadian rhythms are royally screwed up, okay? We do, you know, again, affect that by changing the lighting in the space station. And in fact, the lights now are tuned to be the right wavelength and everything to simulate daylight as opposed to, you know, incandescent lights or what have you. But again, issues. And we talked about neurovestibular. So wow, that was a quick run through of some of the physiologic changes of spaceflight. As I said, we are trying to do some things to help those. Exercise has been paramount in that. Here's a picture of the treadmill. You can see how the harnesses fit over the shoulders, because something's got to hold you down on that treadmill. Okay, you can't just run on a treadmill. So the harness is the gravity, and it does compress there a little bit. Sunny Williams here actually is a fairly elite runner, so she ran a marathon in space. I.e., she ran the equivalent of 24 miles, you know, 24 point whatever a marathon is in space. She's a fun person. I think she was an old Navy helicopter pilot before she was an astronaut, or a young Navy helicopter pilot. Our engineers have been pretty clever in developing the ARADS, the exercise device. And you know, it's important because you have to try to, you know, it's not just a bunch of rubber bands, or you can't lift weights because weights are weightless, right? So, I mean, it's a very complicated system. It has to be isolated from, just like the treadmill has to be isolated from the vehicle, so you're not shaking it all around. And you have to be working the right muscle groups, and it has to be, multifunctional to work the upper, the lower, the torso, what have you. So they got some very clever equipment. But remember, we talked about a mission to Mars and everything. We talked about what happens if you can't exercise. Look at the size of this equipment, okay? That's fine in a space station, which is as big as your house. But if you're on your way to Mars, you're on your way to Mars in a can, all right? There's no way any of these devices will fit in that environment. So that's going to be a challenge for the future. Here's the Russian Chibis. It's a lower body negative pressure device. You kind of get into this little device, and it sucks negative pressure on the lower extremities. Sort of pseudo-gravity, if I could call that. I mean, it's a big extension. It's used mostly for investigative studies, but the Russians have used it a little bit therapeutically as well. So we don't fix everything, okay? In fact, we have some countermeasures, but a lot of energy has to go into rehabilitation, not just prevention and on-the-spot treatment. And roughly, the crews go through a rehabilitation process that is about equal in time to their time up in space. So for a space mission of about 6 months, they have about 6 months worth of rehabilitation. And gradually, most systems return to some level of baseline. Bone density, we're not so sure of right now. And of course, the neuro-optical changes here, we don't have a good return to baseline either. And what's not pictured on here, of course, is radiation, because there is no return to normal there. You've been exposed to it, or you haven't. So who are the physicians, because that's what this lecture is all about, right? The primer on aerospace medicine. Who are the physicians who take care of these people? What are they, okay? So what do they do? What's their job description? Well, they're epidemiologists, because they take part in the selection and the retention of crew members. What does it take to become a crew member, okay? What does it take to stay a crew member? And I know when I worked for NASA, these are my words, not NASA's words. It was like, well, how healthy do you need to be to go into space? Well, I've done some consulting for Virgin Galactic now, which is one of the commercial companies, okay? And again, my words, not theirs. The paradigm has changed. It's now, how sick can you be and still fly in space, right? And Blue Origin has launched 90-year-old William Shatner, okay, who I'm sure wouldn't have passed a NASA physical exam, okay? I mean, nothing against him, but I just don't think he would have passed, okay? So you have to be an epidemiologist. You have to be preventive medicine, okay? What can we fix, before they go up there, or what shouldn't we, should we send them all up there on Lipitor, okay, on atorvastatin? Sorry, no drug names here, generics only. Should we send them all up there on atorvastatin? Because, radiation does increase atherosclerosis. Should they all go up there on atorvastatin? You're the primary care doc, okay? Because you're the doc who really interfaces with them on the ground as well as there. There's occupational medicine things, okay? So you're not just taking care of, the sniffles or the urinary retention, which you might take care of here in the patient, but you might be taking care of toxic exposure to some of the hypergolic fuels or something used on the shuttle, things that are unique to that particular environment that you don't see here. You're an emergency medicine doc, because trauma happens, okay? And you're an EMT transport thing too, because maybe you can't treat it there, and you need to have some type of evacuation procedure in place. The prior slide, you're a rehabilitation doc. As you get your patient, your crew member, back to Earth, and you have to now build up those things. And of course, we all know telemedicine now. COVID helped us with that, but long before there was COVID, okay, there was some telemedicine, but there was certainly telemedicine in spades in the spaceflight program, because your patient was always 250 miles away, right? And hopefully you're also a biomedical investigator, because we don't know all the things that happen, and we don't have all the answers to what happens. So we do need to have the continued research, so you have to have that mindset. Unfortunately, you're a little bit of a pathologist too, because aircraft mishaps do occur, They've occurred in the aeronautical industry. They have occurred in the aerospace industry as well. And you're a little bit of a mini space engineer, okay? Because you do have to understand the vehicle and the systems at least a little bit. Not enough as engineer to design or run them, but to understand their impact upon the human organism. So how do we assess the risk? And how do we decide what we're going to take on a space mission? So NASA has gone through a lot of painstaking research to say, okay, what medical conditions might we expect to occur in a 40-year-old, in a 50-year-old, in a 60-year-old, okay, in a female, in a male, okay? And then what other things might we expect to occur because they're in space, okay, or they're in this particular environment or what have you. And so get some idea of the possibility of getting a kidney stone or getting a heart attack or whatever, and try to determine some level of possibility that this malady will occur. And then what impact might a situation have? Is it a medical problem with long-term effects? Okay, is it something that can be handled within a short timeline? Is it something that would be a major degradation in their performance? And you can look at some of the other categories here and see that how this matrix was basically formed, and then decide, okay, do we need to plan for this? Is this a showstopper? Is this something we can live with? So for instance, the easy part, let's take both extremes. You have something that can be handled within, a short duration kind of thing, maybe you got a skin rash, that a little steroid cream is going to help, okay? And it's, rather than a skin rash, which is highly likely, it's highly unlikely to occur, okay? Well, that may be something you don't even need to plan for, or at least because you can handle it, plan for it with a little tube of steroid or something, okay? That we're going to fly a tube of steroid. But on the other hand, you might have something that is an acute crisis that's beyond the medical capabilities that's extremely likely to occur, and that might be a showstopper. Okay? Or you might have to create extensive resources to handle it. Okay, and you have to decide what you're going to do. Are you going to commit those extensive resources? Are you going to eliminate people who are likely to have that condition, et cetera, et cetera? So this is the risk matrix that we go through in deciding what crew members we're going to fly. And then eventually it comes down to something like this. LEO, by the way, is low Earth orbit. And so NASA has basically said, okay, if it's just a short time, we're going to basically, give you a first aid kit with a few Band-Aids, and that's going to be the system. However, if it's going to be a lunar or planetary mission now, which are coming up with the Artemis program, we are going to need some significant autonomous medical care, okay? Because we won't be able to handle it all here from Earth. They're a little bit on their own, and we've got to prepare them the best we can in that scenario. So, what are you going to take in your black bag as you go up in space? Well, this is what we have now in the black bag, okay? We do have a bunch of medications, all right? Both routine medications, nasal decongestants, steroid creams, that kind of stuff, maybe some blood pressure medicines or something. We do have down here in the lower right some emergency supplies as well. The questions with medications are very significant, is in that, and you will probably, if not taken pharmacology already, soon will. What are the pharmacokinetics? Okay, that's based on volume distributions and metabolism, et cetera, et cetera. Well, we know some of that stuff changes in spaceflight. We know the microbiome of the gut changes in spaceflight, so maybe absorption is different. So we haven't really done the studies on every medicine possible even. There's just been a few candidate medicines, some Tylenol or whatever, that looked at the pharmacokinetics, so that's going to be an issue. Plus the shelf life. It's one thing to go to your pharmacy here, get your pill bottle, and it says use by December 14th, or throw away by December 14th. It says one thing or the other or something on there, and then you just throw it away and you'll get another bottle. Right? Well, you're not going to do that up in space, and you're certainly not going to do that on the way to Mars. So that's going to be a significant concern. And medicines have been used quite extensively. As I show you down here, these are the acute use and the prolonged use of medications, and you can see that there are quite a number of people who have used a variety medications during space flight. We fly some equipment for them, things you might expect, ophthalmoscopes, we have flown echocardiograms I've already talked about, especially now that things have been miniaturized. We do have the ability to give IV fluids, obviously with a pump, not a drip, because there's no gravity. Okay, so we can take your blood pressure. We have a little analyzer for blood testing. Taking your blood pressure is very similar to what you do on Earth, but simple things that you might do on Earth may become more complicated too. And this is an example, okay? Again, your waiting list, there's all sorts of garbage floating around, okay? Eye irritations or getting something in your eye is a problem. You just can't squeeze something in your eye because the surface tension is the dominant force, and that liquid just stick on your eyeball. You won't be washing the thing away, all right? So here, Tom Marshburn is showing you an example of the eye wash system on board there. Taking care of your patient is sometimes fraught with difficulties here on Earth. Gone are the days of the single, practice office where you sort of had a face-to-face relationship with your patient. Now we have this whole big system of healthcare, a big clinic building across the street, 5 layers of administration to get in. Well, this is the layers between you, the physician, down here on the ground, all right? You're interacting with the internal flight surgeons, okay? Maybe the internet, okay? The internal structures with your patient up here. And we're not going to go through each one of these steps. Just want to show you that the system plays such a big part in delivering healthcare in space. So all the frustrations and complexities that we have here on Earth with third-party payers and everything else don't necessarily apply, but there's a whole new host of issues that apply. So if you are interested in aerospace medicine, there are formal training programs available. The classic residency programs available in aerospace medicine have been in the military, all 3 of these branches of the military. There have been there are currently 2 civilian programs. I'm going to caveat to that in a second. There are 2 civilian training programs in existence. The Aerospace Medicine Residency Program at UTMB has been around since, I think now, the mid-1990s or so. And Mayo Clinic has a program as well. The Mayo Clinic doesn't always have somebody in the program every year, so it is a much smaller program. There have been some new programs that have come up for aerospace medicine residencies at these institutions, one of them being here. It's housed within our Department of Emergency Medicine. The professional organization that deals with aerospace medicine is the Aerospace Medical Association. They do have a student branch or student chapter or whatever that you can join if you're interested. Their premier journals, the Aerospace Medicine and Human Performance. And then, okay, so now how do you make a living doing this? Well, generally, you did it in one of these top 2 categories. You either went to work for NASA, and you were among a dozen or maybe 2 dozen at most people, which made it a little competitive in a country of 300 million. Or you were in the military as a flight surgeon, doing mostly, obviously, aeronautical rather than space-related medicine, as these people were doing space medicine. But now we have a whole host of commercial players in the market, many of them pictured here, that are getting involved in this business and requiring the services of medical personnel trained in this. So where have we been and where are we going? The Vikings set out in warships years ago to reach the new continent. And we took a military rocket, the Redstone, and launched our first person into space. Columbus came over searching for new opportunities in a new land. We landed on the moon. The Pilgrims came in search of a new life, a new society, in their mind, a better way to do things. And we've established the space station as a permanent human presence in space. And it has been continually occupied now for 3 decades. We are on the cusp of the westward expansion. The commercial people NASA is returning to the moon, plans for a moon base, for an orbiting gateway around the moon, eventually for transplanetary missions. The commercial partners are getting into space. Axiom is going to have its space station. Pictured here at the top is the SpaceX Starship, a large vehicle taking a large crew into space. So as we open this up to more people of varied backgrounds with different agendas, we're on the cusp of just seeing how far those covered wagons are going to take us. So I want to save a little bit of time for questions. I don't know how well that'll be able to be handled remotely, but I want to thank you for your attention. My contact information is here. Live long and prosper, and may the force be with you. By the way, can anybody see anybody pick out the Easter egg in this? There you go. Yeah, Yoda, okay. Any questions from anybody? I don't know how we work the remote stuff, so.
I have a question.
Sure thing.
So given all of the different changes throughout the different body systems that are anticipated, it seems like in a lot of these astronauts going up into orbit, what kind of medication protocols are they on? Is there a standardized list based on their risk factors beforehand? And then how does that influence like the payload of medication that ends up going into space?
Yeah. So there is no universally prescribed medication routine. In spite of the fact, as you notice, one of the slides I showed was that bisphosphonates actually are quite effective in spaceflight in protecting the bone demineralization. That is not a requirement, interestingly enough. And I'm not totally privy to the reasons behind that. I've heard some not so complimentary reasons, so I won't even discuss those. But there is no prescribed one. About the one thing that anybody uses at most is volume loading before they come back in to help to replenish it. It's actually a countermeasure we developed back in the 1983-84 timeframe. But having said that, yes, it does alter what's taken up there if we know you have a predisposed condition. So if, you can still fly with mild hypertension, if your hypertension is controlled. So if you're on hydrochlorothiazide here on the ground, we're going to launch you with a bunch of hydrochlorothiazide to take in orbit. So, yeah, but we don't universally, like I alluded to, give a prescription of atorvastatin to everybody. It's all individualized based on what their baseline here on Earth is. Yeah.
How many forced retirements have there been due to radiation loading?
None.
What is that? So we talked about sort of the implications of going into space, but what are for someone who spent an extended amount of time in that environment and then moving back to Earth and getting exposed to gravity again, how does that sort of implicate in terms of life expectancy?
Yeah, so what NASA has a program called the longitudinal study of astronauts. And what they did, and this has been going on at least since the early 80s, might have even been instituted in the 70s sometime, but at least that far. And so what they have done is they have signed up astronauts to come back every year or at prescribed intervals to get reassessed physically, okay? And they have recruited age-matched controls, largely from the Johnson Space Center workforce, but it really is, I guess, open to follow them longitudinally as well over the decades to see if there's, as an example, any increased incidence of cancer in astronauts. And so far, there's no conclusive data out of those studies. Space research has a significant hurdle when compared to ground research other than the fact that you have to do it in space, okay, which is a hurdle enough. The other significant hurdle is N. You know, here on Earth, we've all been come accustomed to the multi-center randomized trial, okay, which usually recruits 10,000, 20,000 people, okay? As I showed you there, we've had several hundred people fly in space, but also, as I showed you there, most of those have flown less than 3 weeks. So as far as the long duration effects of spaceflight, we still literally have a handful of people who've done that. And because people are different, okay, that's why we do 10,000 people in a randomized controlled trial, so that we get some type of spread to the data and understand, is this just happenstance or is this a real effect? So we don't have sufficient N takes a long time to accomplish in space flight. And then you're saddled with the fact, as I said, that your subject is far away. You don't have control over the environment, okay? Maybe the CO2 is going to be high. Maybe it's going to be not so high. Maybe it's going to be terrible. All the other factors that you lose control over. So spaceflight data is subject to all those limitations. And before we make conclusions, you usually need a lot of information. We don't just have that yet.
You showed the slide about what a physician working in the space industry looks like, and there's obviously many factors, different specialties that are involved with that. And I know with most of the residency programs that are currently in the U.S., just particularly, I guess, within the emergency medicine department, and with it now going towards the private industry, and things are going to be opening up here, I think, quite a bit. Do you see that model continuing within, aerospace medicine kind of taking hold within emergency medicine first and foremost, and then branching out, or do you see it having, other things in play?
Yeah, so again, the premier civilian program in the country at this time is at UTMB, and they get board certified in preventive medicine. The aerospace medicine is under preventive medicine. And indeed, as I showed you, there are a lot of aspects that deal with that. It's preventive occupational medicine is the actual name of the board. And as you can see, there are a lot of aspects that really pertain to that. The new programs that I showed you up there, Baylor, UT Houston, UCLA, Harvard, those programs are being based out of the departments of emergency medicine at those institutions. So there's an interesting paradigm there about the pathway in which to go there. I look at it as peripheral angiography, okay? If you go back a ways, if you had a blockage in your leg, okay, atherosclerotic or thrombotic or whatever, okay, a vascular surgeon was the person who went in, cut you open, fixed the blockage, and made you all better, all right? Then catheter technology came along. And of course, the surgeons were not so interested in this at first because they cut, this was competitive technology. The cardiologist said, well, I put catheters in the heart all the time. I put the catheter in a blood vessel that's only 3 millimeters in diameter, and oh, by the way, it's moving. Putting it into a 5 millimeter vessel that's not moving, that's a piece of cake. I'm gonna go do this, okay? And the interventional radiologist then said, well, heck, I'm putting tubes and catheters into blood vessels all the time to deliver chemotherapy or to coil a tumor or whatever else. I can do this, all right? And so they started doing it. And then the vascular surgeon said, whoa, wait a minute. All my patients aren't coming to me for surgery anymore. They're going to the cardiologist and the interventional radiologist. So I'm gonna do these peripheral angioplasty. So now we have at least those three. There may be some other people who've stuck in there. We have at least those three specialties doing peripheral angioplasties. They probably all do it well. I mean, it's obviously individual. There's some guys that do it better than others, but they came at it from a different angle, but they ended up in the same place. So I predict after all the animosity is gone, because when that happened, you know, the vascular surgeons didn't like what the cardiologists were doing, and the cardiologists didn't like what the interventional radiologist, you know, after all the animosity was gone, everybody decided, okay, you know, peripheral angioplasty works. Let's get it done by a competent person trained in the procedure. And I think that's what's going to happen with this, okay? They're going to be coming at it from different angles. You're going to have to learn the same stuff, just like in learning the angioplasty, you have to learn the same stuff. You have to learn the anatomy. You have to learn how the catheters work. You're going to do the same thing in aerospace medicine. But there's going to be some gnashing of teeth in the meantime. Hope that answered the question.
Yes, sir. Thanks.
You bet. All right. Well, thank you all. Appreciate it. All right. Take care.